Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. The first presentation will be role of imaging and characterization of endometrial and cervical carcinoma by Professor Rasha Kamal.
السلام عليكم. بسم الله الرحمن الرحيم. أنا تقريبا نسيت المحاضرة من كتر القعدة. إيه؟ يعني لو نسيت حاجة بفكروني إن شاء الله. The role of imaging in the staging of endometrial and cervical carcinomas. There's a statement said by Benjamin Franklin which says that an ounce of prevention is worth a pound of cure. But when this statement comes to carcinomas, I think it becomes questionable. Could we really prevent cancer? But according to the WHO, 40% of cancers are preventable, and one of these cancers is the cancer cervix that we will discuss today. So I think the answer would be yes. And what confirms this is that prevention is not just prevention of cancer development, but it includes advances in diagnosis and treatment that reduce suffering and mortality from the disease. Knowing this, we should admit that the radiologists play a fundamental role in the management of cancer patients. And a good radiology report should fulfill the expectations of both surgeons and oncologists. A radiologist, of course, is not expected to direct the wind, but he simply has to adjust the sails. And if you want to simplify what a radiologist should do whenever he encounters a case of cancer, we will say that he has to look for cancer, or in other words, detect and diagnose this cancer. He has to know find out how far it has spread, or in other words, to stage this cancer. And he has to determine if treatment works, and that means to follow up this cancer. So in my lecture today, I'm going to discuss with you what the radiologist is expected to do whenever he encounters a case of an endometrial or a cervical carcinoma. We will start by step 1, and that is looking for cancer or detection and diagnosing cancer. عاملين لي distraction جامد قوي please معلش. Okay. To know what is abnormal, we should of course know what is normal. And we will revise together the zonal anatomy of the uterus. The uterine cavity is delineated by the functional layer of the endometrium, followed by the basal layer of the endometrium. And outside we have the myometrium, which is separated from the endometrium by the very important junctional zone. And throughout my lecture, you will know how important that zone is. On an ultrasound examination, we can detect both changes in thickness and cyclic changes of the endometrium. Immediately after menstruation and the early proliferative phase, the endometrium appears as a very thin stripe of measuring about 4 to 6 millimeters. In the late proliferative phase, the endometrium attains this characteristic triple-lined appearance of the ovulatory endometrium, and it measures about 12 to 14 millimeters. And in the secretory phase, the endometrium loses this triple-lined appearance and it appears as a white band which may reach up to 18 millimeters. The postmenopausal endometrium looks exactly like the endometrium in the early proliferative phase. And one important dimension that we should remember is that the postmenopausal endometrium should be around 4 to 6 millimeters. So I have some SMSs for you. The first is that the premenopausal endometrium should undergo cyclic changes, and the postmenopausal endometrium should not exceed 5 to 6 millimeters. And because the measurement of the endometrium is very important, I have another SMS for you. Please do not include the junctional zone in your measurement, because doing so you will add at least 4 to 6 millimeters more to the actual thickness of the endometrium. On an MRI examination, we can also detect changes in thickness, and one of the merits of MRI examination is that on the T2 weighted images, we can see excellent zonal anatomy. The endometrium appears hyper-intense, the myometrium of intermediate signal intensity, and again, this famous junctional zone separates the endometrium from the myometrium. One other merit of the contrast-enhanced mammography MRI is that the uterus usually shows a differential enhancement after contrast uptake. because the greater amount of fibrous tissue in the cervix causes delayed enhancement in comparison to the uterus. Unfortunately, on a CT examination of the pelvis, we can do no measurements, we cannot identify cyclic changes, and we see no zonal anatomy. So one more SMS for you. Please do not recommend CT examination to investigate suspected endometrial or cervical carcinomas. Then we come, when should we suspect the presence of an endometrial or a cervical carcinoma? Close as they are to each other, both endometrial and cervical carcinomas have completely different etiologies, completely different clinical picture, and completely different imaging features. We will do a simple comparison between both of them. The endometrial carcinoma usually presents in the 6th or 7th decades, and only very few women are diagnosed under the age of 35. It usually results from unopposed estrogen, which leads to proliferation of the endometrial lining of the uterus. And the first sign of an endometrial carcinoma is a hyperplastic endometrium with atypia. On the other hand, the cervical carcinoma presents at an earlier age. It presents in the 4th or the 5th decade and is commonly diagnosed under the age of 35. It occurs due to squamocolumnar metaplasia, and to understand this, we will have a look on the structure of the cervical canal. The cervix is divided into an endocervix, which is delineated by columnar epithelium, and an ectocervix, which is delineated by squamous epithelium. The junction between the columnar and the squamous epithelium is the commonest site where carcinomas occur. In young individuals, this junction is present here inside the endocervix, and as we grow up, the junction gradually transfers outwards to become outside in the ectocervix. And this explains why most carcinomas in young individuals are endophytic in nature, and in old individuals they are exophytic in nature. The first sign of an endometrial carcinoma on an ultrasound examination is an endometrium that is more thicker than 5 millimeters, or an endometrium which does not show cyclic changes. And one important thing that we must know about an endometrial carcinoma is that it causes late stromal invasion. And when we apply the Doppler to this thickened endometrium, we will find that there is increased vascularity. On the other hand, a cervical carcinoma presents with a completely different appearance. Both exophytic and endophytic types of cervical carcinoma present by a bulky cervix due to early stromal invasion. This is the appearance in the sagittal view, and this is how a cervix appears in the axial view, with a cervix with a diameter of more than 6 centimeters. And again, if we apply the Doppler, we will find that the cervix shows increased vascularity. Some more SMSs. Please always start with an ultrasound examination and do not forget to apply the Doppler. They can show very early signs when other imaging modalities cannot. And from their names, I think we can deduce then that an endometrial carcinoma grows first in the endometrial cavity, while the cervical carcinoma has a tendency to grow first in the cervical stroma. On an MRI examination, this is the first appearance of an endometrial carcinoma with a thickened endometrium, again more than 5 millimeters, and usually this endometrium has a signal which is lower than the normal endometrium. And fortunately, after contrast uptake, the myometrium and the junctional zone uptake hyper-intense contrast, while the endometrium takes very delayed contrast uptake. As for cervical carcinoma, we have a completely, again, different picture. Both the exophytic and the endophytic variety show a bright T2 signal, and after contrast uptake, they both show homogeneous contrast uptake. And so, some more SMSs, please. Uterine body enhances early, while the cervix enhances late. And opposite to this, exactly, the cervical carcinoma enhances early, while the endometrial carcinoma enhances late. And this is one very important sign that will help us in diagnosing both endometrial and cervical carcinomas. Now we come to step 2, and that is to identify how far has this carcinoma spread. And again, before you stage, you have to know your landmarks. There are 3 junctions that we must all know, and 3 interfaces that we must all identify. We will start by the 3 junctions. The first of them, of course, is the junctional zone, and we have mentioned it before. The second junction is between the cervix and the body, and that is the cervicocorporeal junction. And we can know the cervicocorporeal junction by multiple landmarks. The first is it is at the level of the internal os. It is the level where anteflexion occurs. It is the level where the angle of the bladder is situated. But what is more important than these 3 signs, it is the level when this capacious endometrial cavity changes into this narrow cervical canal. And the last junction is the cervico-vaginal junction, and it is very easy to know the cervico-vaginal junction because it is the level where the myometrium ends. Now we come for the 3 interfaces, and the first one is the interface between the uterus and the surrounding parametrium, and it is delineated by this dark line which represents the perimetrium of the uterus. The second interface is that between the uterus and the bladder, and it is delineated by this fat plane which is present between the uterus and the bladder. And the third interface is between the rectum and the uterus, and it is again delineated by a very thin fat plane. And please, whenever we are staging a case of cervical or endometrial carcinoma, do not forget to do either an axial or a coronal T2 weighted image of the abdomen to identify distant metastasis. And for example, we can find peritoneal implants, and we can confirm the presence of parametrial extension whenever we see dilatation in one of the pelvically sealed systems. So we have to perform a sagittal view because it is essential to detect upward, downward, anterior, and posterior extensions. We have to perform an axial view, which is essential to detect lateral or parametrial extension. And we have to do a coronal or axial T2 weighted image of the abdomen because to prove or disprove parametrial extension and to assess for distant metastasis. Now we come for staging of uterine neoplasm, and for simplicity, we will say that stage 1 is a tumor confined to the uterus. Stage 2 is a tumor that invades the cervix but does not extend beyond the uterus. Stage 3 is a tumor that extends beyond the uterus but not outside the true pelvis. And stage 4 is a tumor that extends outside the true pelvis. And as we all see, each of these stages is divided into A, B, and maybe even C. Having a quick look on this table showing the different management lines of endometrial carcinoma, we are not going to go into details, but from this table, we can simply deduce one thing, that a preoperative staging of endometrial carcinoma is one very important job that a radiologist should do because the management in each stage is completely different from the other. We will do some exercise on staging. This is a 60-year-old female with history of breast cancer under tamoxifen therapy. And this remarkably thickened endometrium on an ultrasound examination in any lady taking tamoxifen should be expected. And it characteristically has some cystic changes. And when applying the Doppler, it showed minimal vascularity. An MRI was requested for this lady. This is her sagittal T2 weighted images, and this is the early post-contrast images. And when we see this area of disruption in the junctional zone, I think it is no more a hyperplasia, and this is actually endometrial carcinoma stage 1B. This is another case with a thickened endometrium of a postmenopausal lady with more than 5 millimeters. But this time, this thickened endometrium has extended to involve the cervical canal. And this is how her post-contrast images appeared. And whenever we encounter such a case, we fall in the dilemma of whether it is a cervical carcinoma extending to the body or an endometrial carcinoma extending to the cervix. And I think we have to remember some of the facts that we have just said. And first, that from their names, this lesion is mainly arising within the endometrial cavity. And it has shown delayed enhancement as compared to the myometrium. And one additional SMS that we have to look at the main bulk of the mass. And applying these 3 rules to this mass, I think we should diagnose an endometrial carcinoma stage 2A. But things would have rested like this, but we don't forget that you have to look for the axial T2 weighted images of the abdomen. And when we see this liver deposit, I think no more it will be stage 2A, and it will be upgraded to be stage 4B carcinoma. Now we move to staging of cervical carcinomas, and again, for simplicity, stage 1 is a tumor strictly confined to the cervix. Stage 2 is a tumor extending beyond the cervix. And stage 3, a tumor extending to the pelvic side walls. And stage 4 is a tumor extending beyond the true pelvis. And again, each of these stages is subdivided into several stages. And again, looking at the different treatment options, again, we will say that preoperative staging of cervical carcinoma is another very important job that a radiologist must do. This is our first case, a 44-year-old female complaining of profuse vaginal discharge. She has this bulky mass in her cervix, and this mass has shown markedly increased vascularity after Doppler examination. This was her MRI examination. The mass showed a hyper-intense T2 signal, and it has shown early contrast uptake. And an axial view was essential in this case because this is a cervical carcinoma of an exophytic type. An axial view was essential to exclude any evidence of parametrial extension. This is a cervical carcinoma stage 1B. This is another case with a large cervical carcinoma, and this case is even more exophytic than the one we have just seen. And the mass showed heterogeneous contrast uptake. And this was her axial images, but unfortunately this time we have here evidence of parametrial extension, and this parametrial extension has even extended to involve the pelvic side walls. And so, to prove this, an axial T2 weighted image showed dilatation of the left pelvic ileal system, and this case was diagnosed as a cervical carcinoma stage 3B, an exophytic type. This is another case showing, again, a heterogeneously enhancing cervical mass. But unfortunately, again, in this lady, her posterior wall of the bladder showed nodular infiltrations. And this was her axial image showing a marked parametrial extension. And it was even more clear on the contrast images. And this further proved the parametrial extension, and she had one additional sign that she had pelvic lymphadenopathy, and this was a cervical carcinoma stage 4A. Now we come for step 3, which determine if treatment worked. And again, to know if there is recurrence, we have to know where recurrence occurs. And most endometrial or cervical carcinoma recurrence occurs at the site of the vaginal stump. The remaining patients develop pelvic or para-aortic lymph nodes or show signs of systemic spread manifesting as hepatic, pulmonary, or osseous metastasis. In this case, we have recurrence in the vaginal stump. And this is another case. She received radiotherapy before operation, and you see how her cervix appears attenuated. And lastly, I just want to remind you that cancer is a word and not a sentence. And to the world, maybe a cancer patient may be counted as one person, but to that person himself, he counts to be the whole world. A cancer patient might believe the world has stopped following cancer diagnosis. But we should always remember that it is our role as radiologists, surgeons, and oncologists to change this. And doing a good job simply means making it a new start for that patient. May God bless you all. And at the end of my lecture, I want to thank all my colleagues in the Women's Imaging Unit in Cairo University, specifically Professor Suha Talat and Dr. Sahar Mansour and Dr. Sherihan Fakhri. Thank you.